Hello, and welcome to the first installment of Brady's dynamic lecture series covering respiratory emergencies. It will cover the assessment, treatment, transport, and emergency room care of a patient who presents with difficulty breathing. View the program in its entirety, then log on to the online training academy and complete the corresponding exam. If you have any questions regarding the program, please contact Lieutenant Richardson. Respiratory Emergencies, Case 1. It's a beautiful spring day. You and your partner are dispatched to a local park ranger station for a 24-year-old male with difficulty breathing. When you get there, you find a 24-year-old male patient who presents alert and oriented, sitting on a chair in the classic tripoding position. He's breathing about 30 times a minute with diaphoretic skin. Immediately your mind should start racing. You should start thinking of all the possibilities as to what could cause it. One particular thing that you might think of, it might be an allergic reaction of some sort or an asthma attack. Just two options. What is your initial impression? Well, we just talked about a couple of them. Could be an allergic reaction, could be an asthma attack, could be something else given his history, which we'll find out later. What is this patient's level of distress and why? Well, he's presenting with that classic tripoding position, which we all know, we can think back to EMT class, is a classic indication of somebody that is in severe respiratory distress, or that is having a hard time breathing, rather. We typically don't find people that are in respiratory distress lying down. This tripoding position is natural to us, and pretty much everybody gets in this position when they're having some sort of difficulty breathing, so this should key you in that something is going on. What would be your initial actions? Well, there are many of them you could go with, and we'll talk about a few as we go on. Treatment and assessment. The patient is able to speak in 3 to 4 word sentences and tells you the following. History of asthma. One of the things we discussed might be a possible cause. The attack started about 4 hours ago, and the patient left his metered dose inhaler at home. His difficulty breathing has gotten much worse over the past 30 minutes. Those are all valuable things to think about. And if you remember, again, back to EMT school, asthma is a very life-threatening disease, so don't take it lightly. As you assess the patient, you begin to listen to breath sounds, and you oscillate, and you have full expiratory and slight inspiratory wheezing in all fields. This guy needs some help, and you can tell by the look on the guy's face in the picture, he's having a hard time breathing. Your partner reports the following vital signs. Heart rate of 128 in regular, respiratory rate of 28 in labored, blood pressure of 142 over 100, and an SpO2 of 84% on room air. You also note that the patient has slight accessory muscle use and a prolonged expiratory phase. Has your impression changed with this new information? Well, his history and his presentation has helped to narrow down a few things, for one. So that might change the impression that you have of him. What would be your next priorities? Well, I'm thinking, number one, the type of drugs I'm going to draw up, and still ruling out other things, but kind of thinking along the lines of what possible treatments I'm going to go with. And here's one of them. Your partner prepares a nebulized albuterol treatment while you place the patient on the cardiac monitor and set up for IV access. Do you expect the nebulized bronchodilators to relieve the asthma attack? Why or why not? What stage of an asthma attack is the patient in? Here's what you see on the EKG. Take a look at it. You'll see that the rhythm is regular. We do have a P wave present for each of them. And if you count them up, the QRS complexes, the RR intervals, it is a little fast, a little tacky, so we'll call this sinus tach. You get IV access, an 18-gauge catheter in the patient's hand, and you go ahead and get the 500 cc's normal saline with a micro drip set, and you just set it at KVO. Here you see the patient on the handheld inhaler, nebulizer rather, excuse me. As your partner prepares the stretcher, you note that the nebulizer treatment is almost finished and reassess the patient's lung sounds. You note no changes to the patient's lung sounds. Vital signs haven't changed that much. Heart rate's gone up just a tad to 130 in regular. Respiratory rates 30 in labored. BP of 138 over 100. Your oxygen saturation is going up. It's now at 90 on 15 liters per minute, but we know that's not quite where we want it. What other treatments can you consider for this patient? You've decided to get a little bit more aggressive with your treatment, so you draw up and administer the following medications according to our protocols. You got Epi, sub-Q, of course that's the 1 to 1,000, but we tend to put that down at the bottom of our treatment protocols here in Clayton County. We've got a host of other drugs. You see in the picture there, drawn up some Solumedrol. We carried that a few years ago, but we've now switched over and we administer Decadron. And of course, mag sulfate, IV through an IV drip. And of course, you're going to prepare to transport the patient to the ER. Check your protocols and hang in the mag drip if that's the route you decide to go, and also the proper dosage of Decadron that you would want to administer. And again, this treatment is somewhat dependent on the level of distress that the patient is in. Here you just see him going through IV access to administer the drugs. Reevaluations of the vital signs reveals he's staying constant right around that 128, 130 in that slightly sinus tach phase in regular. Respiratory rate still around 30, and blood pressure is about consistent at 142 over 98. But your O2 sat is coming up, which is our main goal here, showing that those lung fields are clearing up and that he's been able to get better oxygen exchange going on. You note that the patient appears to be getting tired, and you have about a 5-minute ETA to the emergency room. Would you consider intubating the patient at this time? Why or why not? Well, a couple things you can consider. The patient is conscious and alert. He's still able to maintain his own airway. One thing that we ask a lot with asthmatic patients and people with respiratory diseases is, have you ever been intubated? So that's something to keep in mind. They might have some trauma to the larynx that you might want to consider previously. Many things that would come into play as to why you would not intubate. Right now, most people probably wouldn't intubate at this time. But it is something you want to keep considering in the back of your mind. You contact medical control, you give a patient report, knowing that the patient appears to be getting tired, but that you've decided not to intubate. The physician agrees with you in your decision and tells you to monitor and transport, and to intubate only if respiratory failure is imminent. What are some of the concerns with intubation and positive pressure ventilation in the asthmatic patients? At the time of arrival at the emergency department, your patient status has not changed. You transfer the patient to the emergency department staff, and you give your report. There, they continue with the nebulized bronchodilators. They drop the arterial blood gases, and they do pretty much a chest x-ray. See what's going on in there. They're going to administer some drugs that, of course, we don't have on the ambulance with some big fancy names, but they're all designed, again, to treat this respiratory distress. As far as our patient is concerned, they later weaken to the point of impending respiratory failure. They RSI and intubate the patient. That's rapid sequence intubation, and they go ahead and perform endotracheal intubation. The patient is later admitted to the intensive care unit. Review for case 1. The CDC reports that in 2001, 20.3 million people in the United States had asthma. 12 million had an asthma attack in the previous year. In children, it's as prevalent in 5 to 10%, and in the elderly, 7 to 10%. Half of the cases develop before the age 10, and the most common chronic disease in childhood is asthma. The prevalence of exercise-induced asthma on the general population is only 3 to 10%, 40 to 90% in persons with asthma. There's an estimated 500,000 hospitalizations and 5,000 deaths annually from asthma, and it occurs predominantly in males in their childhood, 2 to 1. And as they get older, it kind of equalizes once they hit puberty and early adulthood. Here's a little bit of anatomy and phys review for you. Diagram of the respiratory system, the anatomy. Go into it in a little bit more detail. You've got your upper airway, of course, which comprises of your pharynx and your larynx. You get your nasopharynx, your oropharynx, and your laryngopharynx. And in the larynx, you have your epiglottis, your vocal cords, your thyroid cartilage, and your cricoid cartilage. Further breakdown of your upper airway. Remember, key points that you want to remember too is that children, this anatomy does differ in size, and the structures are not quite the same as with your adults. So that's something to consider too when you consider intubating and just treating the patients as well. Your lower airway, you have the trachea, your main stem bronchi, your bronchioles, your tertiary bronchioles, your respiratory bronchioles, your alveolar ducts, your alveolar sac, and your alveoli. The bottom portion here, from the bronchioles down, are controlled by your smooth muscles. So think about what drugs we use in our respiratory distress protocol that affect your smooth muscles, your corticosteroids, your smooth muscle relaxers, and whatnot. More for you to look at. This is those bundle of grapes. If you think back to EMT school, they were described as a bundle of grapes, where you get that oxygen carbon dioxide exchange. The respiratory epithelium. This is made of your gobulate cells, your mucus layer, and other epithelial cells. A little bit of the pathophysiology. The chronic inflammatory disorder of the airway is characterized by reversible airflow obstruction secondary to increased responsiveness to multiple stimuli. The pathophysiology includes bronchial hyperresponsiveness, your smooth muscle contraction, mucus production, airway inflammation. This can be acute or chronic. Your bronchial hyperresponsiveness is an exaggerated response to external and internal stimuli. The degree of airway response usually correlates with clinical severity. The mechanisms involved include direct stimulation of airway smooth muscle, indirect stimulation of airway smooth muscles, the mast cells, degranulation, and smooth muscle hypertrophy. Mucus production is caused by an increase in the number of respiratory epithelial globulate cells. Chronic mucus plug formation is caused by and consists of a mixture of serum proteins, inflammatory cells, and cell debris. May take weeks to clear up. Acute airway inflammation results from the recruitment of cells into the airway. You get your mast cells, histamine and other mediate release, intense immediate inflammatory reaction. And if you think back to A&P, all these big fancy sonophils, macrophages, and neutrophils, an additional mediator release contribute to the inflammation. Chronic airway inflammation is characterized by the persistent epithelial cell damage and repair process. They result in microscopic changes to the airway and the thickening of basement membrane. There are two phases of an asthma exacerbation. You have phase one, which is the first 1 to 2 hours after exposure to the trigger. You have bronchial constriction secondary to histamine release and a mild airway edema. Phase 2 happens 6 to 8 hours after exposure to the trigger. You have an invasion of the respiratory epithelium by immune cells and a significant edema, swelling, and mucus production. So think back to our patient here, and one of the questions first posed, which was, what phase of the asthma attack do you think he is in? Again, ask yourself that question based on these criteria and see where you think this patient falls initially. Another slide showing what happens, some part of the pathophys with the mucus production. Wheezing occurs as the narrowed airways begin to obstruct the airflow. Early in exacerbation, wheezing heard at the end of the expiratory phase. As the wheezing moves towards the beginning of the expiratory phase, then into the inspiratory phase as airflow restriction worsens. Air gets trapped in the distal airways, and the prolonged respiratory phase allows for total exhalation. Some triggers for asthma could be a sensitivity to medication, could be allergens, pollen, or pet dander. That's pretty big this time of year, and it gets pretty bad here in Georgia and continues throughout the summer and early fall, so something to think about. Irritants can come from paint fumes, cleaning products, exercise. Asthmatics need to be careful about how hard they exert themselves while they're exercising, because it can trigger an attack. Some type of viral respiratory infection, and sometimes a cold, dry air. We don't really have a whole lot of dry air around here because it's so humid, but that cold, dry air a lot of times can cause and trigger those asthma attacks. Some symptoms you'd look for the classic triad: the difficulty breathing, the wheezing, and the coughing, that chest tightness, and that sputum production. Other signs: tachycardia, tachypnea, pulsus paradoxus. Think back to what that is. It's a paramedic school, or you may have even learned it in EMT school. That's basically when your systolic blood pressure decreases by greater than 10 on inspiration. So just look out for that. You'll have wheezing, decreased breath sounds, again that prolonged expiratory phase, chest hyperinflation, the hyperresonance percussion. We don't really do a whole lot of percussing on the back of the bus on the way to the hospital, simply because it's just hard to hear. It might be something you try if you have time inside or before you get moving, but again, that's something that we really don't see a lot of out in the field. That pale, cool, and diaphoretic skin. Signs of severe exacerbation include decreasing levels of consciousness. Again, a lack of oxygen is causing this. Absent lung sounds, accessory muscle use, and cyanosis. Their O2 sats will decrease. Their end-tidal CO2 decreased early in exacerbation, secondary to hyperventilation. Could be normal, elevated later in the exacerbation phase. And on the capnogram, you'll get the shark fin appearance. Here's a picture of that. You can see it there at the bottom. That's what it looks like compared to the normal one up at the top. Kind of has that shark fin shape at the bottom there, you see. Spirometry, you get the forced expiratory volume in ones, FEV1, the peak expiratory flow rate, management decisions based on comparisons of your forced expiratory volume and your peak expiratory volume with patients' known best or predicted values. Sequential measurements are useful to determine the response to their therapy. One of your major treatment concerns, this is drilled in our head from day one, is to ensure that there is a patent airway. You can use BLS or ALS interventions as necessary. Endotracheal intubation should be reserved for those patients in impending respiratory arrest. Think back to that decision we talked about when you're going to intubate and when you're not going to intubate. Numerous complications associated with intubation and mechanical ventilation of the asthmatics. Those are all things you want to take into consideration while you're treating. You want to ensure adequate oxygenation and ventilation. Of course, we're going to go with the high flow 100% O2 via non-rebreather mask. This is not the time to break out your nasal cannula. And of course, we'll do bag valve mask ventilations if necessary. You want to initiate an INT, get you an IV going, and consider the need for fluid administration. Again, we're going to go with the nebulized treatment here. Beta-2 agents are preferred. We use Provenal, albuterol, trucks. Percutaneous, adrenergic agents, Epi 1 to 1000, sub-Q, we administer it. Terbutaline we don't have, but it's another drug out there and another option. Anticholinergic agents, you got, again, some more drugs we don't carry, the nebulized ipratropium, bromide. Has a cumulative effect when it's administered with beta-2 adrenergic agents. Corticosteroids, highly effective in the treatment of asthma. It's onset of 4 to 6 hours. Just a couple of names for some of the ones that are out there. Methylprednisone. Flovent might be a common name that you hear. Asthmacort, MDI, your inhalers. Mag sulfate, smooth muscle relaxant, indicated in severe exacerbations. Works wonders when you have somebody that's actually in that severe respiratory distress. Treatment in the hospital. There's some things that they might give there. The theophylline provides bronchodilation of the small airways, improves respiratory muscle endurance. It's administered through IV infusion. It's extremely toxic. It has a risk of seizures, cardiac dysrhythmias at plasma levels greater than 30 micrograms a milliliter. Anytime a drug is measured in micrograms, you know that it's pretty potent stuff. Mast cell modifiers, they control the mast cells mediated release and eosinophil recruitment. They decrease airway inflammation and bronchial spasms. There are a couple of examples of them. Again, drugs that we don't necessarily have on the back of our ambulances here. 5 lipoxygenase inhibitors. Leukotriene inhibitors, they prevent the formation of leukotrienes that result in smooth muscle contraction, stimulation of mucus secretion, and the recruitment of eosinophiles into the airway epithelium. This concludes the first installment of Brady's Dynamic Lecture Series covering respiratory emergencies. You are now ready to log on to the Online Training Academy and complete the corresponding exam. Should you need further clarification regarding any of the content you have viewed, please contact Lieutenant Richardson in the training department.